right, so let's go ahead and get started. And we have COVID-19 vaccinations and epilepsy. I'll start off for those of you who don't know me, the few here. My name is Naomi Manuel, and I'm with the Epilepsy Foundation of Hawaii. This foundation's mission is to lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to find cures and save lives. We provide education, advocacy, referrals, and support for individuals and their caregivers impacted by seizures. We really want to thank Dr. Stein for taking the time out of his busy schedule today to talk story with us about vaccinations and epilepsy. But before we get started, I'm going to unshare my screen so Dr. Stein can get his up.
Thanks, Naomi. All right, so let me start my sharing.
So yeah, as you share your screen, I have this whole long bit about housekeeping and putting yourself on mute, being respectful of the speaker and participants, but I think we're small enough that I can skip that. I know vaccinations are a hot topic for many for various reasons. So anyone on the call, feel free to ask relevant questions. I just ask that on this platform, we be cordial and respectful to both the speaker and other people who've taken the time out of their evening to get information directly from an epileptologist. This talk is being recorded and will be available for future viewing. So with that said, I would like to introduce Dr. Alan Stein. He was the first epilepsy specialist or epileptologist in the state of Hawaii and founded the Hawaii Epilepsy Center in 1999. In 2002, he moved to the Queens Medical Center as the medical director of epilepsy and neurophysiology for the next 16 years. He specializes in the diagnosis and treatment of epilepsy and seizures, and more recently has served as a physician informatics, optimizing computer systems for physicians and hospitals, and was recently elected as the chief of the newly created Department of Neuroscience at the Queens Medical Center. He is also a clinical assistant professor of neurology at the University of Hawaii John A. Burns School of Medicine. He has served as president and treasurer of the Epilepsy Foundation of Hawaii from 1999 to 2015, and has served various positions as the president, secretary, and treasurer of the Hawaii Neurological Society from 2006 to the present. Dr. Stein grew up in Madison, Wisconsin, and moved to Hawaii in 1998 to start the Hawaii Epilepsy Center. He is a technology enthusiast and appreciates nerd culture. He is married with 2 children and spends his free time trying to surf, playing with electronics, and spending time with his family. Dr. Stein, it's all yours. Thank you so much.
Well, thank you very much, Naomi. You know, the one thing that I didn't put on my bio because 99% of the time it didn't make any difference up until about a year and a half ago is that my undergraduate degree is actually in medical microbiology, which is the study of, germs, including viruses and the immune system. So I actually have some background that predates my medical training that actually somehow came in handy 30 years later, unfortunately. Anyway, so I'm going to talk about COVID vaccine and epilepsy. And I will tell you up front that this talk is 95% about the COVID and COVID vaccine because having epilepsy really doesn't have a lot of impact on whether you should get the COVID vaccine or not. But we'll talk about some special considerations towards the end. Oops, so now I got to figure out which button to press to advance my slides. Okay, there we go. So first off, let's just talk about some background on COVID. What is COVID? So COVID-19 is the official term for the disease or the illness that's caused by the SARS-CoV-2 virus. So for definitions, COVID stands for coronavirus disease. That's what the COVID stands for. And 19 was the year that it was discovered or emerged, which was the year 2019. The SARS-CoV-2, that's the name of the virus. SARS stands for severe adult respiratory syndrome. CoV is coronavirus, and 2 is the second coronavirus that has caused the SARS type of illness. The first of those was the SARS-CoV-1, which you may or may not remember was because there was an outbreak of SARS in Southeast Asia in 2003. So what is COVID? So COVID is a disease or an illness. The symptoms may appear 2 to 14 days after exposure to the virus. and people with tend to have these symptoms: fever or chills, cough, shortness of breath, difficulty breathing, fatigue, muscle or body aches, headache, new loss of taste or smell. That one is relatively specific to this virus, but things that you can get with a gazillion other illnesses: sore throat, congestion, runny nose, nausea, vomiting, or diarrhea. So most of these symptoms are pretty non-specific, meaning that you can have the same symptoms with lots of other illnesses. The loss of taste or smell is relatively specific to COVID. And you might have heard it. People say, "Oh, it's just like the flu." It's not. And so let me just kind of go over this. While mild cases are frequent with both the flu and COVID, the number of more severe cases with COVID is much, much higher. So only about 1 out of 1,000 people who get the flu actually die from it. Now, a lot of people get the flu, and if you look at how many people die from the flu every year in the United States, it's tens of thousands. But that was because millions and millions of people, got the flu. For COVID, it's not 1 out of 1,000, it's 30 people out of 1,000. You're 30 more times likely to die if you get COVID than you are if you get the flu. So it's, again, 30 times more likely to die with it. And it's also spread much more easily than the flu. It's interesting, I don't have a graph or a graphic to show you here, but if you look at the number of flu cases in the United States, beginning in the fall of 2019, it was just a typical flu year. Just as many people were getting the flu in November, December, January of November and December of 2019 and January of 2020. Just as many people were getting it as got it in previous years. So it was kind of ramping up to be a pretty typical flu year. And then COVID hit, and in March we kind of went into lockdown, right? And then there were no more flu cases. As soon as we went into lockdown in the United States, there were no more flu cases. I mean, there were a few, but it was like nothing. And all of the 2020-2021 year, so the winter that we just got through, there were no flu cases because everyone was wearing masks, they were social distancing and stuff like that. So even though there was no flu being spread anywhere in the United States, there was still a ton of COVID being spread. So COVID is much more easily spread than the flu. And we know that the mechanisms that we've asked people to do, wearing a mask and social distancing, we know it works because flu went away. Now, flu comes back every year because flu actually gets spread originally from birds. So that's how it gets spread throughout the world. So you can't make the flu go away just by stopping it in people. But we know that when we ask people to social distance and wear masks, people stop spreading the flu. And I guarantee you, they also largely stop spreading COVID, but it's just so much more easily spread than even that wearing the mask and social distancing didn't completely stop it the way it did with the flu. Anyway, as I said here, in a typical year, 30,000 to 60,000 people die of the flu every year. In a normal flu year, in the last month, more than 30,000 people have died from COVID. So we've had more people die from COVID in the last month than we normally see die from the flu in a single year. Okay, so COVID is not like the flu. And so here at the bottom, I say, don't be fooled into thinking COVID is not a big deal just because your auntie had it and she's fine. And I was going to make a graphic, and maybe I'll make one for the talk I give on Saturday, but I don't know the exact numbers, but Hawaiian Airlines, each plane holds about 200 people. And I don't know, they have, 50, let's say they have 50 flights a day, which I think is a small number. That's like, transporting 10,000 people a day. Imagine if, one flight every single day crashed and everybody on that plane died. That's what the risk is of dying from COVID if you get COVID. The same as if, Hawaiian Airlines flight crashed every single day. And if Hawaiian Airlines flight crashed every single day, or a United Airlines flight crashed every single day, or Southwest Airlines or any airline, if they had a flight that crashed every single day, you would stop flying, right? You would be scared to death of flying, and appropriately so. You would not fly if you knew that when you got on that plane, there was a 1 in 50 chance that that plane was going to crash and you were going to die. Okay, so that's what I want people to think about when they think about COVID. It's not a benign, it's not a mild thing. Sure, most people in that scenario would get on a plane and 49 out of 50 flights would go fine, but that one flight out of 50 that crashes, everyone would die. It's kind of the same thing. You might get COVID, and most people who get COVID are going to be fine. It's not going to be a huge deal, but there's going to be a lot of people who are going to die. Okay. So anyway, so that's a little bit about COVID. Now, what is, this SARS-CoV-2? It's a virus. What is a virus? So most people kind of know what a germ is, like a bacteria. It's like something that can grow by itself, but a virus is very different. A virus cannot grow by itself. A virus needs to get into a cell, and it hijacks the cell to make more of itself. By itself, a virus can't live, it can't reproduce itself. It has to get into a living organism. They just don't have the machinery to reproduce themselves. And medications can't kill viruses. We can use antibiotics, and an antibiotic will actually kill a bacteria, but it won't kill a virus. We have some illnesses that we can help with medications, but the medications don't actually kill the virus. They just kind of make it harder for the viruses to spread or use your body's mechanism to reproduce, but they don't actually kill the virus. So how do they actually cause infections? They have to get into living organisms in order to reproduce. And that can mean people, it could mean pets, insects, plants, even bacteria can be invaded by viruses. But any particular virus is very specific about what kind of organism it can infect. Okay, so the virus that causes distemper in your dog can't infect you. Some viruses can infect multiple different organisms. So rabies can infect dogs and people, but other viruses can only infect very particular hosts. And so now on rare occasions, a virus can mutate, meaning it evolves, so it can infect a different kind of organism. So for instance, there may be a virus that normally infects a monkey or a bat, and then it mutates or evolves, and now it can infect a human. So for instance, we think that HIV infection originally came from an infection in monkeys, and it changed, and then it was able to infect humans. And then we think that the SARS COVID virus was originally a virus that was in bats, and then it mutated and was able to infect humans. So again, viruses need to get into a cell in order to be able to replicate, because it uses the cell's machinery, and they'll usually attach to like a specific part of the cell. And so we call that a receptor. And so they need to be able to attach to that receptor to get into the cell. And then once it gets into the cell, then it can kind of hijack the cell's machinery. And oftentimes the cell will then die, because it turns into just becoming a virus manufacturing plant. And all it does is it manufactures the viruses, and it doesn't do its own job. And then eventually that cell will die, and those viruses will be released, and then they'll infect other cells nearby. And that's kind of how it spreads within the body. It spreads human to human. If we talk about the COVID virus, when you breathe or you cough, because you've got some little droplets, that the cells in your lungs, some of those have died, given up a bunch of viruses. Now the viruses are in your secretions, and when you cough or when you talk, and little tiny droplets of spit and saliva go out into the air, that's where that virus can then spread to somebody else. Okay, so how does your body fight these virus infections? So whenever you get an infection from any kind of germ, which could include a bacteria or a virus or anything, your body learns to recognize it as a foreign invader, so it can respond quickly the next time you're infected. All right, and so your body knows what kinds of proteins are your own, and it can recognize what if you've got proteins in there that aren't yours, it's like, oh, this is a foreign protein. We need to fight this. And so it creates what are called antibodies. And that antibody can attach very specifically to the protein. And we call that thing that it attaches to, the protein, we call it, it's called an antigen. That's the technical word for it. Now, if you look at an antibody, if you could look at it under like an electron microscope, you'd see it kind of looks like a Y. And at the ends of it, at the ends of the Y, so there's two of them, one on each side, right? So at the ends of it, that's where it will attach to that protein. That's where it will attach to that antigen. And so this, the sticky parts are at the end of the Y. Now, how does that help? So you can imagine here's like a picture of the COVID virus, and all these antibodies are going to kind of attach to it or stick to the outside of it. And by sticking to the outside of it, number one, it may make it hard for that virus to actually attach to the part of your body that it needs to attach to get into the cell. And also when it's covered with antibodies, your other mechanisms within your body, basically your white blood cells, they have a much easier time of recognizing that there's something wrong and grabbing onto it and then basically gobbling up this and destroying it. It basically releases a bunch of bleach and hydrogen peroxide and stuff like that to neutralize it once it brings it into its cell. The white blood cells are really good at kind of scooping up foreign material and killing it and making it not harmful. So now, if one of your cells is infected with the virus, your body may recognize it as being infected, and by the same immune mechanisms, kill the cell in your body. And for some illnesses, that is actually kind of how a lot of the symptoms happen. That your body is busy fighting the cells that are infected and creating a lot of immune products and inflammation products, and that what actually causes a lot of the symptoms. Okay, so what is a vaccine? How do they work? So vaccines are a way to introduce your body to the germs without actually, causing an infection. And there's a variety of ways that it can do it. So some viruses or some vaccines use a live virus that's similar but not dangerous to a real virus. So for instance, the chickenpox virus uses a live vaccine or a live virus, but it's a very weak form of the chickenpox virus. And so your body, learns how to recognize the chickenpox virus, but the virus that gets injected is a safe virus. It's not something that causes a lot of problems. For some viruses, they actually use the real virus, but they kill it. And so it's a dead or disabled virus. And that's, for instance, some flu vaccines are that way. Some vaccines use part of a virus. So for instance, HPV, which is the human papillomavirus, that causes some cancers like uterine cancer or cervical cancer. So we have a vaccine for that that's been out for the last 10 years or so. And that uses basically a chunk of the virus. So it's not the whole virus. It's not enough to give an infection, but it's a chunk of it. And then some viruses or some vaccines use a different virus, a safe virus or a benign virus, but they modify that virus to look more like the target virus. And so, for instance, for COVID vaccines, there's 3 vaccines in the United States. The Johnson & Johnson vaccine works like this. It's actually a different kind of virus called an adenovirus, but they modify it so that it actually has little parts of it that look like the coronavirus. And so you get the injection, that virus kind of goes to work and creates a lot of the little bits that look like the coronavirus. And then your body makes an immune response or antibodies to the coronavirus in addition to that adenovirus. And then you might have heard about this new type of vaccine. It's called the mRNA vaccine, which is the type of vaccine that the Pfizer vaccine and the Moderna vaccines are. And so I'm going to talk a little bit about that because this is a brand new type of vaccine. So in any way, the COVID vaccines, what they do is help your body create antibodies against what's called the spike protein, which is that part of the virus that I circled over there, because the spike protein is what's used to attach to your cells and get into your cells. And if they're all covered with antibodies, then it can't attach to your cells, to the receptors of your cells. It can't get into your cells. So that's what the COVID vaccines do, is they create antibodies to this spike protein. So as I said, the Johnson & Johnson is a kind of a traditional vaccine. It uses a harmless virus called an adenovirus, which is like a common cold virus, and they modify it. They added a little bit of DNA so that when it invades your cells, it tells your own cells to make the COVID protein, not the whole COVID virus, but just this spike protein. And so then your body makes this protein. Your immune system knows that it's not a normal protein, and it makes antibodies to it. And then if you ever do get the COVID infection, it says, hey, we've seen this protein before. We've seen this spike protein. We have antibodies to it, and we can very quickly mount an immune response and get this under control. Okay. So what is an mRNA vaccine? This is the Pfizer and the Moderna. So in our bodies, and so I'm going to get a little bit into kind of basic science, and apologize if you get lost here, but in our bodies, we make proteins all the time, right? And how do we make our proteins? Well, we have DNA in our bodies, and the DNA has a blueprint for making the proteins. And the way that the blueprint works is there's usually, you've only got, one copy or two copies of any given DNA strand. And so there's only one or two of these blueprints, but our cells can use that template and make lots and lots of copies of what's called mRNA. And the mRNA then becomes the template that's actually used to make the protein. So DNA is used as a template to make mRNA, and then mRNA is used to make the actual proteins. Okay, so there's a little bit of science of how we make proteins. So what the mRNA vaccine, the Pfizer Moderna vaccines do is that we man-made some mRNA that encodes for making the spike protein of the virus, right? So this mRNA goes into, gets into your cells. We have a way to get it into your cell. And then once the mRNA is in your cell, it doesn't replicate it all, but it is just a blueprint for your body to then say, oh, here's mRNA. I know what to do with this. It's a blueprint. It's a template for me to make proteins. And so it just starts churning out protein because it has the mRNA, which is the template for making protein. So then your cell is starting to make a whole bunch of this spike protein. And then it releases it, and your body says, oh, that's not the protein that we normally see. Let's make antibody to that. And so then you've got antibodies to the protein. Okay. So sorry, so let me go back. So that's how these vaccines work. They help your body or instruct your body to make a bunch of this spike protein, and then your body makes antibodies against the spike protein. And then if it ever sees real COVID, it's already got antibodies to the spike protein, and it can use those antibodies to fight off the infection. Now, the thing is that just like bodybuilding, the more often your body sees a germ, the stronger it gets at making a response. Okay. So while a new vaccine introduces a new germ to your body's defenses, over time, your response might get weakened and your body kind of starts to forget about that germ. And so we use booster shots to reawaken your body's immune response. And so you might have heard about, getting booster shots, which we're starting to give. And that's the reason why, because the booster shots are really kind of like, okay, going back to lifting weights. And I just want you to know it's not unusual for vaccines to need booster shots. So for instance, if we look at, this is a list of a whole bunch of vaccines that little babies get, right? Some get at birth, and then 1 month, and then another shot at 4 months and 6 months or whatever. And you can see that almost every vaccine that we give, kids are getting 3 or 4 doses. And then for the influenza, which is the flu, the real flu, you get a vaccine every single year. Okay. And if you think about like a tetanus shot, well, if you get a big cut, you go to the emergency room, they're going to ask you, well, when was the last time you had a tetanus shot? Oh, you haven't had one for 10 years? We're going to give you a booster shot. Okay. And so you get a booster shot of tetanus every 5 to 10 years. And so with these COVID vaccines, generally for the 2-dose ones, you got a second shot at 3 weeks or a second shot at 4 weeks. But you probably are going to need another shot at, and they're saying 8 months. Now, whether or not that gives you immunity for life, or that gives you immunity for the next 8 months or the next 5 years, or the next 10 years, I don't know. But it's not unusual at all. It's actually normal that vaccines, you do need to get booster shots. So I don't want you to think that, oh, why do I need to get a booster shot? You need to get a booster shot because that's just the way that the body works, and almost all vaccines work that way. So I want to talk about some of the myths that people have heard about, this vaccine. So the first thing is not a myth, but the COVID vaccine was developed in record time. But I want you to know that no part of that process was rushed. So if you might have heard, oh, I heard the vaccines were rushed. No part of that process was rushed. Well, why does it normally take, 5 or 10 years to create a vaccine, but we were able to get this one like in less than a year? Well, because you had every single vaccine researcher in the entire world working on this one vaccine. Okay. Normally, it's like, oh, let's make a vaccine to chickenpox. All right, well, how much interest is there, and how much money are they going to make with that? And how, do you really need a chickenpox vaccine and whatever? And so there's going to be a few people who are going to work on making a chickenpox vaccine, but you're not going to have a gazillion people working on making a chickenpox vaccine. But when COVID hit, holy cow, this was, a pandemic. Everybody in the world was affected by it. Everybody started trying to figure out how to make vaccines for COVID. Okay. Every researcher in the world who worked on vaccines. In addition, there was this new technology, the mRNA vaccine that I just talked to you about. And that technology had actually been under development for almost 20 years. And it was actually ready to go when COVID hit. It was just by chance that, when COVID hit, we had this new technology that had been under development, and it was ready to go. And then we also knew a lot about COVID vaccine because we had the previous SARS outbreak. Remember, when I kind of gave you that definition of why is it called SARS-CoV-2, because there was actually a SARS-CoV-1, which was the Southeast Asian respiratory syndrome in 2003. And so people already learned a lot about these coronaviruses and about this, what I call the spike protein, and how to create a vaccine. They didn't need it because that whole little epidemic kind of faded away because it was not as infectious of an illness as the current COVID is. So they didn't need to use that vaccine. So they never got to the point of developing the final version of the vaccine, but there was a lot of work being worked on it. So they really knew what to do when it came time to develop a vaccine. Okay. Now, these COVID vaccines were given an emergency authorization approval, but because the data was, this was a pandemic, it's an emergency. So the data was reviewed quickly. It was reviewed just as thoroughly as other data was, but, it didn't go into a queue to say, okay, well, we'll get to that one in, 8 months. We got a bunch of other stuff to review first, and we'll eventually get to that one. It went to the front of the line for obvious reasons. So it was reviewed quickly. And the data was overwhelmingly clear that it was safe and effective. And so they gave it the emergency authorization. And there was a lot of pressure to do that. COVID was killing on average 9,000 people a day worldwide. And waiting just a little while would have led to millions of additional unnecessary deaths. So they really, they put it to the front of the line and they looked at it. And then they took the normal process, the normal time, and they went through the completely normal review process. They looked at every bit of data. They crossed their T's and dotted their I's. Everything that they saw confirmed what the initial results looked like. And so they gave it the full approval a few weeks ago. Okay. And there were no new concerns raised about this, about this vaccine. This was the Pfizer vaccine. And the Moderna is almost certainly coming soon. Okay. So another thing I heard of, well, it wasn't tested on very many people. So don't look at the top part. I want you to look at the bottom part. I want you to think about, I want you to see some numbers here. So for instance, on the epilepsy drugs, and so, you know, for anyone who's in the audience who's taking epilepsy medicines, Keppra, which is our most common seizure medicine used. Originally, it was tested in the first study it was tested in was 268 people, a third of which got placebo. So really about 200 people got the active drug. Now there was a second trial, so total of about 400 people got the actual drug. Vimpat, similar numbers. Epidiolex, which is CBD oil, only 156 people finished the study, half of whom got placebo. So really it was only tested on about 80 people in that study. And then there was a second study about another 80 people. So only about 150 people total in the entire world went through the testing process for some of these common seizure medicines, okay? By comparison, if you add up the Pfizer vaccine, the Moderna vaccine, and the Johnson & Johnson vaccine, it was tested in 100,000 people. Actually more than that, 120,000 people. So, you know, 600 people for Keppra versus 120,000 people for the COVID vaccines. It was just phenomenal number of people got tested with it. Okay, phenomenal number of people were tested. This was a very highly tested vaccine. They needed to test it in so many people because they wanted to get the results as quickly as possible. And so they have to give the injection and wait to see how many people get sick, how many people actually get COVID. The more people they can give the vaccine to, the quicker they'll get to the number that they need to see how many people got COVID. So they gave it to, so 100,000 people went into the testing program. Half of them got placebo, half of them got the real stuff, but this was a huge, huge studies, okay? And did they work? The answer is yes. Unequivocally, absolutely, positively, the vaccines work. So what kind of data do we have on that? So for instance, in the Pfizer trial, 44,000 people were tested, half got placebo, and there were a total of 10 people within the study period, within a couple months that they were looking at it, 10 people actually came down with severe COVID. 9 out of those 10 people got placebo. Only 1 person in the 10 got the mRNA vaccine. In the Moderna trial, there were 196 symptomatic cases. So Pfizer was severe cases, like people who needed to be in the ICU. The Moderna trial were people who got symptomatic, meaning that they, you know, lost their taste or smell and they, you know, had a cough and things like that. So out of those almost 200 people who were symptomatic, 185 of them got placebo and only 11 people got the actual vaccine. And in the Johnson & Johnson trial, they looked at severe and critical illness, again, kind of like the Pfizer trial. 85% of people who got sick had gotten placebo. So the placebo was 85%, the real drug was 85% effective in preventing severe and critical illness. Now, they didn't test all 120,000 people. They didn't do a nasal test. If you ever had one, they're not real comfortable. They didn't do that on everybody every other day to see how many people actually got infected. They only looked at people who actually got symptoms, who actually got sick. And that's actually what we care the most about, right? If it was just, you know, like getting the cold, no one would care. What we care about is that, you know, millions of people are dying, okay? And so, so these were the numbers during the vaccine trials. Now, since that time, in the United States, something like 200 million people have gotten vaccines. We've got about 350 million people in the United States, and something like almost 200 million of them have been vaccinated. So how is it working in the real world? This was the clinical trials, this was the studies, whatever. How does it translate into real people, real world? And all I can tell you is our experience in Hawaii. So this is how many people are in the hospital with COVID-19 as of last week, September 2nd, okay? And this is with the Delta, right? So this is with the Delta variant, the variant that is, you know, much, much, much more infectious. It's not necessarily more deadly. It's just that so many more people are getting it because it's so easy to spread. This virus is super duper spreadable. Now in Hawaii, about 60% of the people in Hawaii have gotten vaccinated. So if the vaccine didn't work, you would expect that 60% of the people in the hospital would be vaccinated, right? If the vaccine didn't work, you'd have just as many, the same percentage of people in the hospital who got vaccine as as in the general population, but it's not like that at all. In reality, if you look at the Queens Medical Center, which is where I have these numbers from, on September 2nd, there were a total of 149 people who were hospitalized. 22 of them were vaccinated, 127 were not vaccinated. So it's about 95% of the people who are in the hospital were not vaccinated. In the ICU and on ventilators, meaning on a breathing machine, the numbers are even more striking. Only 2 people in the ICU or on a ventilator didn't get vaccinated. Everybody else, 35 people, were not vaccinated. Okay, so the numbers here, it's about 95% effective at preventing you from getting into the ICU or on a breathing machine, which is exactly the numbers that we saw back in the clinical trials. So real life data says that this is just as effective in real life as what we saw in the clinical trials. And the people who are getting really sick and the people who are dying and the people who are on breathing machines are the folks who didn't get a vaccine. So please get a vaccine, because then even if you get sick, you're not going to get as sick. You're probably not going to end up in a hospital. Okay. So this gets me to my next point. People are still getting COVID-19 even though they're vaccinated. And that is true because no vaccination is 100% effective. But the COVID vaccines are 95% effective in preventing severe symptoms and death. And it's the unvaccinated people who are ending up in the hospital. Another thought was, well, I already had COVID-19, so I've already got immunity, right? The answer is you might. I just saw a study, and I just saw it literally the other day after I put together these slides. It said about 1/3 of people who get COVID infection, they don't have persistent antibodies, so they don't have long-lasting immunity to it. And then a study out of Kentucky showed that people who had previously been infected with COVID-19 but got the vaccine anyway, so people who had been infected but still got the vaccine, they were half as likely to get COVID a second time as the people who had COVID the first time and didn't get a vaccine. Okay, so even if you had COVID, last month or 6 months ago, you should still get a vaccine. Okay, you should still get a vaccine. So the next question is, are the vaccines safe? And the answer is yes. Okay, now I'll tell you that every medicine, even Tylenol, can have side effects. And by the way, Tylenol kills plenty of people every year from overdose. It's actually very, very dangerous to take an overdose, but just as using Tylenol is something that everyone thinks is harmless, any medicine can hurt you. In the COVID vaccine trials, people got local side effects or what we call reactogenicity. So you get this injection, and then your body starts making this protein that your body sees, oh, this is a foreign invader, starts creating an immune response to it. Just by having the immune response, people get some symptoms. It doesn't mean you've got an infection. It doesn't mean that anything terrible is going on. But typically, most people will get pain in their arm. I certainly had a sore arm for about 5 days after my second injection. There might be some redness and swelling in that spot. And then throughout the rest of your body, you might be tired or fatigued or have headaches or muscle pain or chills or fever or nausea. And these side effects usually happen within a day or two of getting the vaccine, and they're normal signs that your body is building up protection. And those symptoms should go away within a few days. So I've heard people say, and I'll be honest with you, not many of my patients have had bad side effects from it, but I have heard some people say, oh yeah, I felt kind of crummy, felt pretty crummy for a few days. Let me tell you, you're better off feeling crummy for a few days than ending up in the ICU on a breathing machine. So there have been some very rare but dangerous side effects. So the one you probably heard about was blood clots in the Johnson & Johnson vaccine. And when they looked at it, they found out that that was happening in a rate of about 1 million per million, or 1 person per million doses. Okay. And out of those, there were 3 reported deaths, but there were 13 million people who got the Johnson & Johnson vaccine. So again, think about it, that out of 1 million people who get COVID, 30,000 are going to die just from getting COVID. And here, 13 million people got the vaccine and 3 people died. So it's extremely rare. There were deaths, but they were extremely rare. Now, the clots were less common in older women and in men. They're primarily in young women, okay? And by the way, young women do get blood clots more often for other reasons as well, including for birth control. Definitely causes blood clots, and women get it who are on birth control. And smoking and birth control pills are a bad combination for exactly this reason. So this happened, but it was quite rare and certainly less common than we see in some other medicines that people take every single day. You might have heard that it caused some inflammation of the heart, and this was reported in about 1 out of 100,000 people who got the mRNA vaccines. This one was more frequent in young men. No reported deaths of some people who were hospitalized. The average duration of hospitalization was only 2 days. Okay, so this was, again, a quite rare thing to happen. So the other thing I want to let you know is that just getting a COVID infection also causes blood clots and also causes heart inflammation. And there's a much, much higher rate of blood clots and heart inflammation in people who actually get COVID-19 than in people who get the vaccine. So even though there's a very tiny chance of getting blood clot or heart inflammation from getting the vaccine, there's a much, much, much higher chance of that happening to you if you actually got infected with COVID. So the best way to avoid getting these problems, blood clots and heart inflammation, is to avoid getting COVID-19 in the first place. And the best way to avoid getting COVID-19 is to get vaccinated. So the next question, and this is why you all are here today, is, are the vaccines safe for people with epilepsy? So the talking points from the Epilepsy Foundation of America. So this isn't just me talking. This is like the official Epilepsy Foundation of America. There's no evidence that people with epilepsy are at a higher risk of side effects after getting a vaccine. As with any vaccine, some people may get a fever, and having a fever may lower their seizure threshold for a short period of time. And this rarely could result in having more seizures, but there's no evidence that the vaccination causes worsening of epilepsy or brain injury. So I will give you an example. I had a patient I just saw today, and she got her second COVID shot a couple of weeks ago, and she got a fever. She had a pretty high fever, and she had a lot of seizures. But she has a lot of seizures every couple of months. That was not really anything majorly different from her. And so it can happen. And what we tell people is, if you know that you tend to get seizures when you have a fever, there are some extra things that you can do to try and avoid getting the fever. So as I said, elevated temperature is common after getting the vaccine, et cetera. So I think I have my next slide is what you can do. So if you're worried about getting seizures with a fever, here are some suggestions. First, take over-the-counter medicines that hold down the fever. And this is things like Tylenol, but as I said, don't overdose on it. Don't take it more than the directions say. Ibuprofen, the trade names are things like Motrin and Advil, but generic ibuprofen is just as good. Or aspirin, okay? So all of these things help control fevers, keep your fever down. And if you're someone who tends to get seizures when you have fevers, this is one way of keeping your fever down. The other thing is, you may want to talk to your doctor. Can I take extra medicine for a few days around the vaccine? Okay, I'm going to get my shot. Can I take extra medicine for a few days, for 3 or 4 days around the time of my shot? And it might be an extra dose of your regular medicine, or it might be certain medicines that we give, like when someone's having a whole bunch of seizures, like lorazepam or clonazepam or Valium. So talk to your doctor, because hopefully your doctor will say, sure, and they'll, depending on what medicine you're on and what dose you're on, is probably safe, but definitely talk to your doctor about that, okay? And then if you do get a fever, you can use a cool compress to keep your fever down, like some cool, put some rags in some cool water, some towels or washcloths, and then you can put that, on your body to keep your fever down, or you can take a cool shower. So that's a way to keep your fever down, okay? So finally coming to the end. So in summary, COVID-19 is a severe infection and is caused by the specific virus called the SARS-CoV-2. If you're infected with the SARS-CoV-2 virus, or if you get a vaccine, your body will learn to recognize that virus and will be much better able to fight it off in the future. The COVID-19 vaccines have all been well tested, and they've been proven to be safe and effective. Severe complications from the COVID-19 vaccines are from the vaccines are extremely rare, and they occur at a much lower rate than the same complications from an actual infection of COVID-19. And COVID-19 vaccines are safe for almost everyone with epilepsy. And while fever that sometimes occurs after vaccination can briefly worsen your seizures, is generally with the same types and severity of seizures that you already have. And then the last thing I want to leave you with is that it's been estimated that vaccines so far in the United States, and that we've only had vaccines for about 6 months, that's already prevented 140,000 deaths in the United States. And unfortunately, people are still dying of COVID, but it's mostly people who have not gotten a vaccine. So please, please get a vaccine, because that's the best thing you can do to prevent getting COVID and prevent dying from it. So I think that's the end of my slide. I've got one or two additional slides if anyone asks a question that is relevant to my slide. So I'm going to pause my share. Okay, so I don't know if you can see, go back to seeing Naomi, but I'm happy to take any questions.
If anyone has any questions, please feel free to unmute yourself and you can ask. I guess I could ask a question about children. People have
Sure.
a lot of concern about the vaccine in children. Do all the points you make, does it all relate to children as well?
Sure. So, right. So the COVID vaccine, only one of them has been approved for children, and that's age 12 and above. So the Pfizer vaccine has been approved for ages 12 and above. So I don't know the data in the younger children, right? So they've been looking at it in younger children, I think age 2 through 12. But I haven't seen any of that data yet. But that's why we have the FDA. So if the FDA approves it, then we'll know that it's safe for kids. What I can tell you is what I know about the approval for age 12 to 16, because the original approval was for age 16 and above. And then I think it was in May, I'm trying to remember because it was when my daughter got it. It's either May or June. My daughter, who's 15, wasn't able to get get it until it was approved for age 12 to 16, and so she got it. So it looks like that is everything I said that applies to adults also applies to that 12 to 16 age group. And hopefully within the next couple months, it will be approved for younger children, and then we'll know more about what the data says about the safety and efficacy in that group. That group is becoming more of an issue because when the vaccine was first approved back in December, the first group who got the vaccine were people like me, were doctors. And then after that, doctors and first responders and nurses and healthcare workers. And then after that, it opened up to elderly folks. And there was a mad rush. Boy, it was impossible to get a reservation to get the vaccine. And so I think I read that about 90% of people age 70 and above are vaccinated. So it's mostly the people who are unvaccinated. Those are the ones who are getting really sick. And that's mostly in younger ones, younger people. So not just kids, but younger adults as well. So we've actually had a lot fewer deaths with the latest COVID surge than our percentages would have predicted from our first year of COVID. But that was because most of the really vulnerable people had gotten vaccinated. And the people who thought, well, I'm not vulnerable, right? I'm young, I'm healthy, I'm not going to get really sick. Well, guess what? Some of them are getting really sick and some of them are dying. And so now we're actually seeing some little kids getting severe COVID and ending up in the ICU and unfortunately rarely dying as well. So, and now that the public schools are back for in-person learning, there's a whole lot of young kids together. When COVID first hit and we were first starting to put the rules in at our hospital, the first thing we said was, and actually maybe this had to do with actually during our flu season, little kids cannot come and be visitors in the hospital. Below age 5. I think that was actually the rules for when the flu was going on. And someone was like, well, why can't little kids come? Because little kids don't know how to not rub their snot on stuff and not cover their nose, when they're coughing or sneezing. So kids, spread germs like nothing else. I remember when my kids started in preschool, boy, I had never had so many colds in my life as when my kids were, 2 years old in preschool, because those germs went around like crazy. Well, now we have kids in the public schools, and thankfully they're mostly not getting really sick when they get COVID. But if they get COVID, man, they are really good at spreading germs, including COVID. So anyway, I don't know. Hopefully that answered your question. Any other questions? Oh, you're muted. You're muted, Naomi, I think. Sorry, I can't hear you. Uh-oh. Yeah, no, it definitely says you're muted. Okay, here's a chat. Look at Minnie's question. Thank you, Dr. Stein. You should be sharing this information with all patients, not just epilepsy patients. Also, what would you recommend for the booster? Can we use the booster from another company for broader coverage? Minnie, that's a great question. And I wish I knew the answer. I don't think that they approved it for that. I actually kind of wish that they did, because there might be slight differences between the vaccines. So from a scientific standpoint, it sure makes sense to be able to do that, but I don't think that's what we're going to do. So I think that if you got the Pfizer, you're going to get a Pfizer booster. I think if you got the Moderna, you're going to get a Moderna booster. And I don't know for sure, but I think they're going to do boosters for the J&J, but I'm not 100% sure about that.
Okay, can you hear me now?
Now I can hear you, yes.
Oh, it's so weird. It jumped to another microphone. Oh,
okay.
God. Okay, so I guess I have another question about long-term effects. That's another burning
okay.
for a lot of people. I know you mentioned that the mRNA has been, they've been studying it for over 20 years, but what are some of the long-term effects that people may be able to expect from these vaccines?
So we are not aware of any long-term effects of the mRNA vaccine, okay? So the way the mRNA vaccine works is it can't make more of itself. It can make the spike protein, but eventually the mRNA wears out, and it's not a virus itself. It can't make more of itself. So you can't have lingering mRNA in you that's just churning out, more and more of it, and it can't reproduce itself. So theoretically, there really shouldn't be any long-term effects from the mRNA vaccine versus any other kind of vaccine. And we're not aware of any long-term effects. Now, on the other hand, for people who actually do get the COVID infection, there is this thing that they're calling long COVID syndrome or long haul syndrome. And to be honest, we really don't understand very much of it. We don't understand it that well. But again, that's not from the vaccine. That's from people who actually got the COVID infection. And we don't understand that. So again, the best way to prevent getting COVID, long COVID syndrome is to avoid getting COVID. And the best way to avoid getting COVID is to get vaccinated.
Any other questions, anyone? Here's your chance. I guess I'll have one more question to end it out. So the Pfizer, Moderna, and Johnson & Johnson, these are offered worldwide. Do other countries have their own vaccination?
Yeah, so in the United States, these are the 3 that were approved. I don't know if other vaccines were submitted for approval or not. Honestly, at this point, I don't think another vaccine, it would make economic sense. It costs a lot of money to go through FDA approval. And, between Pfizer, Moderna, and Johnson & Johnson, they've got the United States covered. Other countries have their own vaccines, and they may also use these 3, but they also have their own vaccines. So I'm trying to remember the names of it, but I know that, for instance, China has one or two of their own. I saw some early data that said that they were not as effective as ours. Saw the same thing with a vaccine from the Soviet Union. There's a vaccine in the European Union that I'm blanking on the name of it, but there was some controversy as to, same with us, gosh, is this causing blood clots? And they looked at it and they said, well, kind of similar to what we've seen. There's a very rare risk of having blood clots, but they've continued to use those vaccines. So there are different vaccines in different countries. I think that these 3 vaccines are also being used in other countries as well. The rich countries, us, Canada, Northern Europe, those are doing well in terms of getting vaccines out to everyone, the same way that we were initially, until people lost interest. The real problem, I think, in the world right now is in the developing countries. Like, India had a terrible surge. You may remember that in the news, a couple months ago, because they just don't have the infrastructure. And it took everything that we could do to get 200 million people vaccinated. Well, in India, that's only 1/5 of the population. So even if they could get 200 million people vaccinated, to them, that's a much smaller percentage than 200 million people in the United States. Anyway, so yeah, there are different vaccines in different countries.
Thank you for answering those questions. Anyone have any other questions? I don't see anything in the chat. No one else? No burning questions? Well, if anyone doesn't have any more questions, I just want to thank you, Dr. Stein, for all that information. It's very helpful, and it was presented in a way that is digestible to many people. So I thank you for creating that presentation and sharing it in the way that you did. So this, I'm going to end this in a little bit. Right now, I'm going to end the recording. Just to let you know that this same talk is going to be on for next week, Saturday, September 18th at 9 o'clock in the morning. If you need to hear the information again, or if you feel that it's important for someone else to hear, please refer them to our website on epilepsyhawaii.org. And at the bottom of the website has the registration to all of our events, but it'll be housed there. So please feel free to share this information. This will be available on our YouTube channel probably by tomorrow. But it's great to be able to have access to an epilepsy specialist and ask those specific questions that you would want, that you want to know. So please visit us and join us if you can next time, or just share the information. And Dr. Stein, thank you so much. We really appreciate it.
Well, thank you, Naomi. Thanks for the opportunity to spread some actual, science and give me an opportunity to dispel some of the myths that are going out there with this vaccine. Yeah, I'm gonna definitely share this video with some people. Okay.